Hello, my name is Luke Haddock. I am a second-year respiratory therapist student at Vermont Tech in Williston, and this is my project description report on the implementation of sustained maximal inspiration at the University of Vermont Medical Center. So normally at the University of Vermont, we use a device called the incentive spirometer, and its design is essentially to help people take larger breaths when they've had any type of surgery, whether it be thoracic or abdominal. Sometimes they're given to patients that have injured a leg, hurt another part of their body, and potentially can't get around very easily. This is to help from having a process developed called atelectasis, which is when your lung starts to collapse inwards on itself. As this device stands right now, we still use it all the time for patients, and normally nurses are the ones that end up giving it to patients, even though it should really come down to the respiratory therapist to administer this device to a patient to begin with, because it is a lung device and it does work off lung mechanics. So my goal for the project that I want to accomplish is to basically do away with incentive spirometry. On average, the cost of implementation of IS ranges from $65 to $240 per patient in the hospital. And the amount of annual cost when IS is used is around $1.04 billion across the entire nation. So it's very expensive, and we use it a lot for patients. And in my opinion, it's not usually indicated. This project aims to eliminate the huge expenditure of IS nationwide. UVM Medical Center will implement a new protocol to manage atelectasis that involves discontinuing the IS device, and I'll explain that more to you in the next slides. Patients will be evaluated as usual in terms of their overall function and ability to inhale deeply. If they're not able to do standard physical therapy or inhale deeply, they will be instructed on how to do sustained maximal inspiration, which is a new technique that has been used by other hospitals, and there's been some very promising research on this technique. When is IS indicated? IS is generally indicated after an abdominal or thoracic surgery. Patients who have undergone open heart surgery or an abdominal surgery generally have a higher level of pain relating to how they breathe, and this is tough because you really need to take deep breaths after a surgical operation to make sure that you're keeping your lungs open, and it gets worrisome for certain aspects of patients that can't bounce back after a surgery like this because they can't take deep breaths. And a lot of that really comes down to, are they motivated? Do they want to try to get better? And also, do they look at IS as a potential toy, or they don't pay attention to it because it looks like a silly little object? What if IS isn't all it's cracked up to be? So I found this quote, and it's pretty interesting to me. Presently, the evidence does not support the use of IS for decreasing the incidence of post-operative pulmonary complications. Routine use of respiratory physiotherapy after abdominal surgery does not seem to be justified. The most recent meta-analysis found had no evidence of benefit from IS. Which is actually pretty interesting considering that this is a meta-analysis. And meta-analysis is really take in a ton of data and analyze all of it from a bunch of different angles. And with a big study like this, it does show some pretty statistical significant findings that show that IS may not be as good as we originally thought. There are some big downsides to incentive spirometers. They are completely effort dependent. So patients that don't want to comply usually end up playing with this device for 5 minutes, putting it down, and never touching it again. Goes in the garbage, and ends up in a landfill. It's pretty tragic. Nurses will administer these devices all the time, and it's not usually indicated for a lot of patients. I'll see these devices in patients' rooms a lot, and usually I ask the patient if they use it, and they go, maybe sometimes, I don't know, it doesn't matter. And then if I'll try to do it with them, they usually decline and will not follow through with the use of the IS. Many patients fail to perceive their IS as a necessary medical device. 26.2% of patients failed to use their IS correctly, which is interesting because when you look at an IS, it looks like you should blow into it, but really you should be sucking inwards. And that sort of works backwards in your mind in terms of how it looks. And so a lot of people blow into it, which doesn't do anything, when really you need to take a deep breath in, and it'll raise the little flow meter up higher and higher and higher as you get better. But if you're elderly or you don't understand, there's a lot of recoaching that goes involved in this device, and it usually just ends up getting lost in the wet work amongst all the other medical jargon that gets tossed to these patients daily. 38.1% of patients deny using their device during post-op care, which is a pretty big amount of people that just don't use it. They're made of plastic and are used minimally 2.3 times per patient on average before being disposed of, according to Hall et al. At this point, I'm going to say that IS is a huge waste of time and money. The device is outdated. They're no more effective than taking a deep breath. How can we ensure the best patient care? The outdated approach, each patient that has any lack of ambulation, meaning walking, doing any sort of movement, gets an IS from a nurse. They bring it to them, and the patient gets to see this little device that they might not ever touch again. The nurse usually, a lot of times, don't really instruct how to use them. They just give them to them, and then hopefully they figure it out. They're not super worried about what complications could come down the road with this. And usually, if they're in the hospital, they're going to heal in a few days, hopefully. But if they're wiped out for a longer amount of time, then there should be some more serious measures taken in terms of what we would do for their lungs. And that usually involves more serious devices that would help with lung expansion therapy, not necessarily an IS device that is just solely based off your own ability to do it and your own willingness to comply. So my new approach that I'm proposing is that IS is unnecessary in all patients that have had thoracic surgery and qualify for an IS based on an evaluation from a respiratory therapist, is that they will be evaluated in terms of, are they walking, are they moving, can they cough, can they get a little bit of exercise, are they completely non-compliant? In that case, it's kind of a lost cause. You can do what you can for patients that don't want to comply, but at the end of the day, they're going to end up sort of being a slug, and that's just like how they like to live their life, and that's fine. That's their choice. So in this whole mishmash, pish-posh, they will basically we'll evaluate for an intervention for these patients, and in this intervention, we will basically explain to the patient a new way of how to help their lungs through this post-operative process. How do we evaluate patients? Each nurse will have to communicate to an RT if they think that a patient fits the criteria for hyperinflation therapy or lung expansion therapy. If the patient is not walking, they're not moving, this definitely fits the criteria. If the patient does not fit the criteria, then they'll be excluded. But essentially, we will instruct the patient on some deep inspiration breathing and work with them to teach them how to do it. If the patient does comply and can do deep inhalation therapy, then their progress will be monitored. IS will not be indicated for these patients, and definitely not definitely not indicated for unmotivated patients in general. So this is my proposal to how we fix this IS problem. Wasting plastic, tons of money is going towards this device every year. And what it's called is sustained maximal inspiration. The idea is that you will sit upright in your chair or in your bed, and this helps to basically create more of a ability to create this negative pressure in your diaphragm, which will expand the lungs more. You can use your external intercostals, all sorts of other muscles to help you take these deep breaths in. So you'll sit upright, and this will also expand surface area in your lungs compared to if you're just laying down flat. Second, you will inhale deeply through pursed lips slowly for about 4 seconds. Third, once you've achieved maximal inspiration, you will hold your breath for about 4 seconds. At this time, it is best to try to close your epiglottis, and you want to close the epiglottis in the back of your throat and bear down. And what this does is it creates a better intrathoracic pressure that will help distend the alveoli that are inside your chest and keep you from having these collapsed alveoli ever occur in the first place. It's basically doing the exact same thing as an IS, but with an added benefit of the epiglottic closure and creating that intrapleural pressure that is needed to help expand those alveoli. Fourth, you will exhale over the course of another 4 seconds until maximal exhalation has been reached. Repeat this process 5 to 10 times an hour if you are a candidate for this hyperinflation therapy, which is very important. Through the night, I wouldn't be too worried, but it could help to, if you wake up in the middle of the night, if you're a person that has a hard time sleeping, to do it at least once or twice throughout the night. If and also you'll be dealing with a lot of pain too if you're a post-op. So it's good to try to be keeping that in mind. And also these patients are also candidates for a chest x-ray, which will be able to determine further if further steps will be taken to help hyperinflate their lungs if they do develop post-operative atelectasis. So what can decrease the likelihood of atelectasis? Essentially early physical therapy. That's the first line of defense, is getting up, moving. It's the best thing any patient can do for themselves, is to just get up and walk around or move a little bit. Do something that picks up your heart rate and your respiratory rate. This will help just open those alveoli and just keep you open. It is the number one most successful way to keep patients healthy. So what I'm in terms of what I want to implement, I have a summarized timetable here, and this goes further into my detailed timeline on my project report. So starting in July, I would like to have my final collaboration with the hospital CEO. That would include myself and the CEO on talking about just completely removing IS, and we'll at that time discontinue IS use, and we'll be switching over to this sustained maximal inspiration for the patients. Come July 16th, we will be withholding all devices, and that will include a bunch of personnel will be involved, and we'll have to basically include the CEO, physicians, nurses, RTs. There will be direct supervision. There will be trainings with nurses and physicians on how to do the sustained maximal inspiration technique, and hopefully people will start really figuring out their own method to their madness in terms of how they want to explain it to patients best, and explain the complications involved with not breathing, doing this exercise, essentially. And then, so at that point, we will be fully enacted in the sustained maximal inspiration we will be enacting the sustained maximal inspiration for all patients at that time. And then come January 2nd, 2020, we will have an evaluation of the integration of this protocol, and we will be seeing the do's and don'ts and how it has worked thus far and how it has helped patients in terms of their overall health and well-being. Thank you for your time. Let's save money, energy, and the environment. Any questions, you can reach me at my email noted here. And these are my references as well. Thank you and have a nice day.